Hello, this is Ginger Keene. I'm the clinical educator for St. Peter's Health Partners, one of the hospitals involved of 9 hospitals for the Critical Care Consortium. This online program is the same content delivered in the Critical Care Consortium ECG course live classes. Electrophysiology is the first lecture for the Critical Care Consortium ECG course. Let me go over the expectations. The expectations for this course is for the students to do the reading prior to the content presented, then watch all of the videos in the order as listed in the website. After each session, there is homework assignments, which again are on the website. It is very important to do the homework and practice measurements and rhythm interpretation. The expectation is that you complete all of the education prior to testing, which will be determined how and when testing will be done by your own facility. So you should check emails and your educators to make sure that you know when and if the testing will be occurring. You will also be asked to pause the video throughout the course in order to do practice strips, which will be reviewed once you resume the video. If you are having problems understanding concepts of any part of this course, please seek help from your clinical educator or mentor at your home facility before the next session, because this course is designed to build on each session from the previous session. Let's get started. Our objectives are correlate the electrical events of cardiac conduction with mechanical events in the heart, identify the components of the conduction system of the heart, identify the waves and intervals of the normal cardiac cycle, utilize an organized approach to rhythm interpretation, and then summarize the nurse and allied health professionals' responsibility in the care of the monitored patients. Don't worry about remembering every detail. The primary focus of this session is these 3 things: know normal conduction, identify the waveforms and normal cardiac cycle, and measure the intervals. That is our primary focus for this session. Let's talk about the cardiac cell properties. Every heart cell or cardiac cell has the ability for automaticity, excitability, and conductivity. The electrical cells are responsible for stimulating depolarization of the myocardial cells, which means making the cell positively charged, which therefore results in a contraction, and then repolarization, which is the recovery of the myocardial cells so that it can again be depolarized and contract again. With automaticity, every cardiac cell has the ability to spontaneously initiate an impulse. That impulse travels throughout the cardiac cells, and it allows each of the cells have excitability and conductivity, meaning that that impulse will travel from cell to cell, because each cell can respond to the electrical stimulus and pass that impulse to another cell, which is very important and is done very quickly so that the cells can depolarize at the same time, causing a contraction at the same time. When we talk about the myocardial cell or the muscle, every cardiac cell has the ability for contractility and extensibility. Cardiac cells cannot contract unless they've been electrically charged or depolarization. So it's important to remember you can't have a contraction without the cell being depolarized. So all of the cardiac cells has the ability to squeeze, shorten, and then return to its original length and stretch. The benefit of the cells being able to stretch is that it's like a rubber band, that the more it stretches, it'll swing back and give a better contractility. So the myocardial cell will stretch and contract in order to pump blood forward. Within the cardiac muscle, there are specific pacemaker cells. And they are the ones that inherit the automaticity. There's several locations within them throughout the endocardium that claim to be pacemaker cells. Any myocardial cell has the ability for automaticity, and the heart will respond to the strongest and the fastest pacemaker cells, or wherever the impulse comes from. Increased automaticity is the mechanism responsible for many cardiac dysrhythmias we will be studying. So examples of this is a sympathetic stimulation that can increase the heart rate, such as fear, pain, anxiety, caffeine, and many drugs that are sympathetic mimicking drugs can increase the heart rate. Other things, it becomes a compensatory response to hypoxia or ischemia. Your heart rate will elevate in order to try and provide more blood and oxygen to the cells, and electrolyte imbalances as well. The degree of automaticity may be decreased by parasympathetic. So sympathetic stimulation causes an increase in heart rate, increased contractility. It causes vasoconstriction so that there's better perfusion. And again, that's your fight or flight. Parasympathetic kicks in usually at rest, or resting and digesting, feeding and breathing is usually the best way to remember what parasympathetic nervous system does. But it can also be triggered with a vagal stimulation, such as bearing down to have a bowel movement, vomiting, coughing, suctioning. And when this vagal stimulation occurs, it triggers that parasympathetic, which actually slows down the heart rate. So you would have oftentimes patients that can develop syncope by vomiting or bearing down to have a bowel movement because their heart rate will drop too low. When we talk about depolarization, this is the process where the cardiac cell in their resting state will normally is negatively charged, and during the process of depolarization will change the inside of the cell from negatively charged to positively charged. On the inside of the cell, you have primary ion is potassium. On the outside, you have sodium and calcium. Now, all of those are positively charged ions. However, also within the cell, there's proteins, a large amount of proteins inside the cell that makes the inside of the cell less positive than the outside of the cell, making it more negative. So during the impulse for the cardiac cells to what we call depolarization, is actually what's happening is the ions along the cell wall membrane is channels. So these channels are triggered by the impulse to open, and sodium and calcium will go into the cell, making that inside of the cell positively charged. Potassium will leave the cell, and what happens is when this cell is positively charged, it will tell the cell to mechanically contract. So without electricity or without depolarization, the cell cannot contract. That is depolarization, changing the cell from negatively charged to a positively charged. Then once the cell has completed depolarization, the cell will go back to its original resting state, and the electrolytes will go back to their original position. So sodium and calcium will leave the cell. Where the channels open up, they leave the cell. Potassium will come back into the cell. And during this process of repolarization, where the cell is going back to its original resting state, the cell cannot accept another stimulus. So it's in the refractory period. So in the process of repolarization, the cell is refractory or resistant to a stimulation from another impulse. It's like there's these absolute and relative refractory periods. So the absolute refractory period during the process of depolarization, It cannot accept a stimulus. But towards the end of depolarization, the heart, if it's strong enough stimulus, again, the heart responds to the fastest and strongest impulse. And if the stimulus occurs during the vulnerable period towards the end of the repolarization or the relative refractory period, it may it may take over as the primary pacemaker from other sites, such as your ventricles, and it can actually cause the patient to go into ventricular tachycardia or other life-threatening arrhythmias such as VFib. So this vulnerable period is very sensitive. Another way to think about this refractory period is like a toilet. Thinking of the QRS as a toilet. So the QRS is what the ventricles are depolarizing. And if you have a toilet, and if you flush the toilet, and if you try to flush the toilet right away after you've just flushed it, it will not respond. But if you wait a little bit and allow the toilet to refill a little bit more, then you can try flushing again. It will flush, but it won't be a normal flush. So it's not fully ready. So that's kind of like the analogy to put it towards the refractory periods. We're going to talk about what normal conduction is. It is very important to understand what the normal conduction is and is the base of what we're going to be talking about going on to abnormal rhythms. So you have to understand what the normal is before you can understand what abnormal is happening. Because all of our rhythms, the interpretation is basically based on where did the impulse originate, and that's part of the interpretation. We're going to talk about the normal, which is the primary pacemaker, which is your SA node. Your SA node sits in your right atrium near the superior vena cava. It's composed of the pacemaker cells, and we call this the primary pacemaker. It fires at a rate of 60 to 100 beats per minute, or impulses a minute. And again, your SA node is your primary pacemaker of the heart. From the SA node, that impulse needs to travel, and it will send the message or the impulse to other cardiac cells. And it can do that very rapidly by going through intranodals, which is your tracts within the atriums, and at the same time it goes to the left atrium and those intranodals, so that both the right and the left atriums can contract or depolarize and contract at the same time. That electrical stimulus of the atria stimulates those muscles to contract so that the blood will be ejected into the ventricles. Once that message is sent, it's going to what we call the AV node. The AV node is located at the bottom of the atrium, right atrium, near the tricuspid valve. And the electrical impulse is now slowed to allow for complete ventricular filling. So the AV node is the gatekeeper to those ventricles. It has to go through the AV node to go down to the ventricles. So it allows a slight pause to allow the atriums to fully empty and squeeze all the blood into the ventricles. If the atriums and the ventricles depolarize at the same time, you won't have synchrony of blood from or filling. It'll just go everywhere. So the goal is the blood empties from the atriums into the ventricles, and then the ventricles will fill and then contract. So that message goes from the AV node, and then it goes to the bundles of His. The bundles of His are tracts located within the septum of the ventricles, and it breaks off into the right and left bundles. The left bundle has two extra bundle branches, which is the anterior vesicle of the left bundle branch and the posterior vesicle. Because the left ventricle is larger than the right ventricle, it allows more opportunities for the impulse to go through the myocardium of the ventricles as quickly as possible so that both the ventricles, the right and left, can depolarize at the same time. After it's gone down the bundles of His, it goes deep into what we call the Purkinje fibers. These Purkinje fibers are located within the myocardium, and these rapid conduction down the bundles into the Purkinje fibers, actually they are the fastest conducting fibers to allow rapid depolarization of both ventricles. These Purkinje fibers also can take over as a pacemaker cells. So your SA node is your primary pacemaker, and it fires at a rate of 60 to 100. Your AV node, or we call it at the junction, if your SA node fails within your AV node, the junction, there are a group of cells that can also take over as a backup pacemaker or a secondary pacemaker. But just like a generator in the house, if your electricity goes out, the generator is not as strong as your primary electricity, so your junction or your AV junction can fire at a rate of 40 to 60. Again, it's a backup so that if your SA node fails, and again, so the message if the SA node fails and the junction fails within the Purkinje fibers, it is a final backup electrical system that fires or depolarizes the ventricles if the heart rate drops below 40. So if your Purkinje fibers or the ventricular impulse that would occur would usually be 40 or less. But it's not very strong, and it does not go back up into the atriums, but it is one way to preserve cardiac output to the best. It's better than nothing, but it's very weak. So that is your normal conduction. So at this point in time, within your website, you should have a picture of the heart. I'm going to show you that. And what we want you to do is to practice labeling these letters and putting them in order, and then we'll review it. So pause this video and then put the letters in the correct, label them correctly, and then put them in the correct order that they would happen. And then turn the video back and resume the video, and then we'll review it. Okay, you should have already done your practice. Let's go over it. So where does your conduction system start? In a normal conduction system, it starts with the SA node, which is D. So your SA node starts, and then you may or may not have put either E or B. E is your internodals, and B is your Bachmann's bundle, which allows the impulse to go to the left atrium, but it basically is happening at the same time. So if you put E first or B first, it doesn't matter, but E is your internodals, and B is your Bachmann's bundle. Then that impulse will go to A. A is your AV node. And the AV node will give a little bit of a pause and then send that message down to G, which is your bundles of His, the start of them, and then they break off into your right and left. And we try to think about which one would go faster, but again, the goal is for both the right and the left ventricles to depolarize at the same time, so that message will go down the right and the left. And in the left, C is the left, H is the right, and then the C will break off into your J, which is your anterior vesicle, and your I is your posterior vesicle. And then finally, that impulse will end up into the F, the Purkinje fibers, which will therefore rapidly conduct the rest of the myocardium to allow it to depolarize. And here's a picture of all of the labels. So we are looking at the basic EKG. Please remember, when you're looking at an EKG or ECG, it measures electrical activity only. You cannot look at an ECG and think that patient has a pulse. because sometimes there's electricity going on in the heart, but you may not have an actual mechanical, which means a pulse. So you would have to feel for a pulse. When you're looking at the electrical activity, you have electrodes on the patient's chest. The picture is what's being picked up and distributed in the ECG when it's a view between a positive and negative electrode. If the view is from a negative electrode going towards a positive electrode, what will happen is you will get a positive deflection. And when I talk about positive and negative deflection, everything comes back to the isoelectric line. Everything above the isoelectric line is a positive deflection. Everything below the isoelectric line, it is a negative deflection. And the isoelectric line is basically neutral. So all of these impulses that are these spikes that are positively deflected, the view is from a negative electrode looking towards a positive electrode. And the electrical activity away from a positive electrode towards a negative electrode will cause a negative deflection. As you can see in this middle picture, many people don't like to look at negative deflection, but again, when you're looking at all of the leads that are on, we'll say even a 12 lead EKG, you have 12 views or 12 pictures of the heart of different angles. So where you're placing the leads, it's actually looking at that part of the heart or between two electrodes in that direction. So some of them are looking from a positive to a negative, which will give you a negative deflection. Some of them are actually in between or perpendicular to the electrodes, and that will give you what we call a biphasic deflection, where it's part up, part down. So this is where a lot of people like to look at lead 2 because it's easiest to identify your P waves, it's easy to look at your QRS, and all the atrial and ventricular depolarization is towards the positive electrode. In this picture, you can see that on the right shoulder is the negative, and the door towards the left part of the chest, which is your left leg lead, is positive. So in this direction, it's looking from a negative to a positive in lead 2, and that is why you have a positive deflection when you're looking in lead 2. And most people like that. But again, you'll have to remember that when you change the lead, it is like looking at different angles of the heart, and a photo is moving, your camera just a little bit to kind of look at the heart in different directions. You can look from the bottom, they can look at right on the top at the septum, it can look at the anterior, it can look at the side so when you have your 12 lead EKG, you're actually looking at 12 views of the heart. We're looking here at EKG paper. So it's very difficult to watch or to look at because it's so small. And one of the things I encourage people to do is get a magnifying glass or get cheaters or download the handouts onto a computer because you can make it look bigger, and that way you can see the small little boxes. So, and if you look really close, you might be able to make tiny little pictures out of it. Otherwise, it'll make you cross-eyed. So what we're looking at, and the reason for the ECG paper, is measurements. So when you're measuring horizontally, you're measuring time. And we're going to be calculating how much time, such as your heart rate and intervals. So we're going to be measuring intervals and your heart rate, and we do that by measuring time. And we do that also by counting boxes. So with that, you break down, and if you break down to one tiny little box, it's a 1 millimeter by 1 millimeter box, and when we measure time, it is 0.04 seconds. I cannot emphasize to you enough that you need to memorize that each of these small boxes is 0.04. So if you have a handout or anything, make sure that you highlight that, write it down in a book, because everything that you're going to be calculating is going to be done in multiples by 4 or 0.04. And hopefully you're good with moving your decimal points. If you have a test in your facility, you can use a calculator, but you cannot use your phone. So if you are unsure about your 4 times table, I'm not the greatest, but you should bring a small calculator because you cannot use your phone if you want to do your calculations for your measurements. So each of these baby boxes is 0.04, and the nice thing about this paper is that it puts it in darkened lines in boxes of 5 by 5 so that you can count by 5. That's much easier to count. So if you were to have a measurement that was 5 boxes and you multiply it by 0.04, you're going to have a measurement of 0.20 seconds. The other thing that the ECG paper has is at the top of the paper, it has these lines, and what these lines are, it gives you between here, if you were to count, 5, 10, 15, 20, 25, 30, 35, 40, 45, 50, 55, 60, 65, 70, 75. There's 75 boxes from one marker to the other, and if you multiply that 75 by 0. You'll get 3 seconds by multiplying 75 times 0.04. Now, you have these markers at the top, so if there's another marker, a 3-second marker over here, then from here to here will be 6 seconds. And we're going to use those markers when we do calculations of our heart rate and using the 6-second method. So just remember, you're measuring time, we're going to be counting boxes, and you're going to be multiplying everything by 0.04. Now, we measure time horizontally. Vertically, we measure voltage, which is up and down, and that's usually determined by the amount of muscle mass and also by effectiveness of surface electrodes as detected electrical activity. Such things that can change that is obesity, or the chest wall, such as in a barrel chest, can make the tracings smaller. Or if you have somebody that has a left ventricular hypertrophy, where they have a thick left ventricle muscle, and the more muscle you have, the more electricity that's going to be going through it, and what you're going to have is a big QRS as opposed to maybe a normal QRS. So just to keep in mind, when you're looking at voltage, you're looking at the amount of electricity going through the myocardial muscle, and that would give you indication of size of the muscle as well. So a normal EKG complex consists of a P, Q, R, S, and a T. That is your basic for everything we will do in this course. And we're going to talk about each one of them and what it means. The first part of the ECG cardiac cycle is the P wave. So the P represents your right and left atrial depolarization. Now, if you look at what on the P wave, it is basically right here that your SA node fires in the beginning of the P. So your SA node fires, and that impulse is traveling through both atriums, the right and left, and making from a negative electrode to a positive electrode in that direction, and that's why it is going to be upright and a positive deflection. The P waves are normally round and upright. Again, that's usually because in the direction you're looking at is from a negative to a positive electrode. You may have some variations in your P wave, and again, this is something to keep in mind. Anytime that you have a change in the dynamics or structure of the heart muscle, the electrical conduction will take different pathways, and it can change the look of such as your P waves. So what can happen is you might have what we call a peaked P wave. So they look kind of peaky, and that is usually due to like a right atrial enlargement. And those patients who are COPDers, they have oftentimes right ventricular pressures are very high because your pulmonary arteries are hypertensive or constricted, so it makes a lot of resistance for your right ventricle to pump against. When your right ventricle enlarges and has higher pressures, your right atrium has to try to pump against or empty into that higher pressure, and that can make changes into your right atrium and making an enlarged. So therefore you will develop what we call as a P pulmonale, or a very peaked P wave. It's the same as on the left atrium. So what we can develop is what we have is a notched P wave, what kind of looks like a little M, and that is P mitriale. And that's usually due to left atrial enlargement. And again, anytime you change the structure or the dynamics of the heart structure, you will have a different pathway or a different look of that impulse as it travels through the myocardium. The other thing that you could potentially have is an inverted P. And that, instead of being positive, it will be negatively deflected. And usually that is due to the impulse is coming from the AV junction. So I'm going to draw a little heart with your right and left. Your SA node starts here, and your AV node is here, and then you have your bundles. So as I said earlier, is your SA node is your primary pacemaker. What can happen if the SA node does not fire, your backup pacemaker, your AV junction, can take over as the pacemaker. Now, the normal conduction of electricity from the SA node is from a negative to a positive. Now, if your AV junction fires, it goes in the opposite direction. So, as you can see, it's going from a positive to a negative. And what that does is it produces a negative deflected P wave because it's going in the opposite direction. So that usually is indicative that it came from the junction. Now the PR interval. The PR represents the amount of time it took for the SA node to fire, go through the atriums, and then go through the AV node. So again, you're going to measure your PR by start where the SA node fired. It went through the atriums. This is where the AV node put the pause on so that the atriums can empty into the ventricles, and then it goes to the bundles of His. So your PR interval would be measured from the start of the SA node firing through the atriums, through the AV node, until it gets to the bundles of His. A normal duration for your PRI is 0.12 to 0.20. And the PR segment, which is when the AV node is pausing, it should be isoelectric, meaning that everything comes back to the neutral line, the isoelectric line. The QRS complex represents depolarization of the ventricles. With your QRS, you may not have all of your waves. You may not have a Q, you might have a QS without an R, you just may have an RS, or you might just have a QS. So looking at these different types of QRSs, and again, it depends on what lead you're looking at, But what we're also going to be referring to all QRSs as R waves. Instead of saying QRS to QRS, we're going to be saying R to R, especially when we do our measurements and our calculating our heart rate. So we are going to name these complexes pretty much R to R. When we look at the QRS complex, please understand that there's different deflections. So your Q wave is a negative deflection. It is the first negative deflection. And of course, it always is before the R wave. Your R wave is the first positive deflection. And your S wave is the first negative deflection after the R wave. So again, your Q wave and your S wave are below the isoelectric line. If it's not below the isoelectric line, it does not exist. So you would not have a Q wave or an S wave. And looking at these examples, such as in A, there's no Q or S. It's just an R wave. In C, you do have a Q, you have an R and an S. In D, you have a Q and an R. In E, you have a Q and an R in different variations of how big they are. In G, you have an R and an S as well as F. Again, you may have a deeper S in some of your leads compared to other leads. And it is just a different picture or view of the heart. So just remember that it is not always, you may not always have all of those waves. When you measure your QRS, you measure from the start of the QRS. If there's no Q, you start from the beginning where the R goes up. And then when you measure where the S wave comes back up to the isoelectric line. Or if there's no S wave, where the R wave comes down to the isoelectric line. And then we call that the J point. So then you would count how many boxes, which makes it very difficult because the QRS is so narrow and it's hard to count those boxes. But you would count in the normal QRS is 0.10 seconds or less. And the goal is for that to be narrow because that means that it came from the atrium. Your ST segment, this is part of the absolute refractory period, and it signals the end of depolarization and the beginning of repolarization. So the cells are now returning back to their resting state or normal. It extends from the end of the S wave, where it comes at the J point, and to the T wave. It is normally isoelectric, and changes in your ST segment can be very important in this patient's diagnostic indicators. If it's ST elevated or ST depression, that is very significant. And let's look at a few examples. So if we have ST depression, again, if you're taking your isoelectric line, your STs are below the isoelectric line. That can be indicative of myocardial ischemia, ventricular hypertrophy, sometimes bundle branch blocks, or hypokalemia, and sometimes drugs such as digoxin. Digoxin can cause this, what we call a scooping, a digeffect, can cause a scooping of the STs. Especially if this is something new, you would want to get a 12-lead EKG and note, because it can also be a sign if a patient is having a non-STEMI. Not to say that it's an absolute emergent, but they would definitely have some coronary artery disease going on and they would need to have follow-up. ST elevation, so if you're looking at ST elevation, you take your isoelectric line and it is above the isoelectric line. And again, your ST segment should be isoelectric. A ST elevation is usually indicative in an acute MI or acute myocardial infarction or injury. It also can occur when the coronary arteries are vasospasming. So patients are having chest pain, their coronary arteries also sit on top of the epicardium, so it supplies the heart itself with blood and oxygen. What covers those coronary arteries that sit on top of the heart is a pericardium. If that pericardium becomes inflamed or fluid accumulates between the pericardium and the epicardium and covers those coronary arteries, it actually can compress those coronary arteries and decrease perfusion to the heart. So therefore it can show ST elevations on a 12-lead EKG. Also, a ventricular aneurysm can also cause ST elevations, and it's usually due to the coronary arteries are not perfusing. But if you see ST elevation, that's significant. That means that patient's having a STEMI and they need to have a 12-lead EKG done as soon as possible, within 10 minutes, and notify the provider. Here's some other examples of ST elevations. Again, if you're doing your isoelectric line, whoops, they're above it. And again, 12-lead EKG, if you are a monitor tech, you would be notifying the nurse. If you're the nurse, you would get a 12-lead EKG and notify the provider, potentially even calling a rapid response. The T wave is the last phase of ventricular repolarization. So the ventricles are repolarizing, the ions are going back to the original position where sodium and calcium are moving out of the cell, potassium is going back into the cell, and again, this is that vulnerable period in the middle of the T waves, around the relative refractory period or the vulnerable period. Normally your T waves can vary, and it can be flipped, inverted, or they may have different sizes. A perfect example of that is if you have hyperkalemia, what happens is your T waves get very tall. And again, during repolarization, your potassium is going back into the cell. And if you have a lot of potassium going back in, thinking about that, that can cause extra potassium to go in and cause the T wave to be big and tall. On the other hand, if you have hypokalemia, what you'll often see is a very low voltage T wave. Because again, if you only have a little bit of potassium to go back into the cell, it's going to take a lot longer for repolarization to occur. So you'll see your T waves to be a lot lower and even longer to repolarize. QT interval. So again, this is where you're going to be measuring your QT intervals routinely. Even though Huff, the book, does not give the answer for your QT intervals, we do, as a consortium, want our people to know how to measure QT intervals, because there's lots of things that can cause a prolonging of your QT, such as hypokalemia, hypocalcemia, hypomagnesemia. Certain drugs can do it, a lot of cardiac drugs, amiodarone, procainamide, tricyclic antidepressants. So there's medications that we're giving patients that can prolong the intervals, the QT, and we want to make sure that we are keeping an eye on that, we're measuring it, and not allowing it to get too long. But when you're measuring your QT, you're measuring the time when the ventricles begin their depolarization towards when they're done with repolarization. So you would measure from the beginning of your QRS to where the T comes back to the isoelectric line. Normally your QT interval is less than half the distance of R to R, and what you will find is that it can vary in age, according to age or gender, and especially heart rate. So the faster your heart rate, the shorter your QT. The slower your heart rate, the longer your QT. And the danger for a prolonged QT means that the vulnerable period is longer than usual and more susceptible to life-threatening arrhythmias. A U wave is usually not seen, and it only happens occasionally, but it usually comes and it's very low voltage. This gives so much more credit to it than it really is. So you might see a very low voltage as opposed to this higher voltage there. But a U wave is just an extension of repolarization. And oftentimes you'll see a U wave in hypokalemia or hypomagnesemia. So it makes sense. So if you're hypokalemia, your T waves will be very low voltage, and oftentimes will have this a U wave, which is basically another extension of repolarization because you have too little of potassium or magnesium. Other things that can cause it is sometimes exercise or ventricular hypertrophy, a CVA, some drugs can cause a U wave. Again, this is a prominent U wave indicates a prolonged ventricular repolarization and can have the same implications as a prolonged QT. The size of it usually is less than 2 millimeters high, less than 2 baby boxes. We just want to go back to that refractory period when we talk about why we're measuring the QT intervals. So the absolute refractory period starts at the beginning of the QRS, or the beginning of the ventricular depolarization, meaning that no matter how strong a stimulus, the heart cannot respond by causing a depolarization. So your absolute, and it winds up to about the middle of the T wave. So this is your absolute refractory period. In the relative refractory period, that actually, in the middle of your T wave, if a strong impulse comes, such as a PVC, a premature ventricular contraction, or if someone is playing a sport and they get hit in the heart right at this very vulnerable time, what can happen is it causes a chaos or a re-entry. So if you can picture, your potassium is going back into the cell during repolarization, and your sodium and your calcium are moving out of the cell, and those channels at this point in time are just starting to close. And but they haven't closed yet. So if a strong impulse occurs, and again, remember, the heart responds to the strongest and the fastest. So if a strong impulse comes in at this time, it can cause a re-entry, or the sodium and the calcium is trying to go back into the cell. And when that happens, it can actually cause chaos and the heart to go into this irregular, dangerous, life-threatening rhythm because of that, causing electrical chaos. So it's very important if you note that, especially if the patient is having frequent PVCs, which I'll draw one here. So if you have a PVC that comes in and early and on that T wave, that too can cause the patient to go into VV tach. So when we talk about the vulnerable period and why we are measuring the QT intervals, it's important to understand that we can't give medications, or we have to hold medications if the QT is too long, or if the patients are having irregular beats, such as premature ventricular contractions. We want to note where they start. If they're coming in on the T wave, we call that R on T, and we'll discuss that more in the ventricular rhythms. So at this time, I'm going to have you do a practice session on page 22, do 3.1, 3.5, and 3.8. In this practice session, I want you to identify the waves, the P, a Q, an R, an S, a T, and a U, if it's available, if it's there. So you may or may not have all of the waves, so look closely and label each of them, and then we'll review it. So pause the video and do the practice strips, and then resume the video and we'll go over them. So hopefully you've done your practice. So in this strip 3.1, we're going to identify the P's. So we have a P and we have a P. Okay, so this is a P and this is a P. They're both upright. They're right before the QRS. And remember, it always has to go in alphabetical order. You have a P, Q, R, S, and T. You cannot have an S before R. You can't have, these are things that just to keep in mind that it has to be in alphabetical order, or you may not have a wave. So in this complex, there are no Q waves. Remember, your Q wave is the first negative deflection. So there is no negative deflection. So therefore, there are no Qs. You just have an R and you have an S wave. Your S wave is a negative deflection as well after the R. Then let's look at our T waves. Yep, you have T waves. So and they are after the QRS. So don't think that this T wave can be interpreted as a P wave. Your P waves are small, your T waves are going to be bigger. So you have a P, an R, an S, and a T. And did you notice that this is considered a U wave? It's very low voltage. As I said, you possibly could miss it, but if we had a longer strip, it'd be a lot easier to see. In strip 3.5, this one's a tricky one. So when we look for P's, I don't know if you noticed, but these are both P waves. There's two P's for one QRS in this. I know it's kind of hard to pick out, and this is something that, especially when we look at AV blocks, that you might have more P's than QRSs. So identifying where the P's are and how many P's there are, this is not a U wave. This is not a U wave. That is too perky for a U wave. U waves are very low voltage and not as perky as P's. So there's two P's for these QRSs, and there are Q waves. The Q wave is the negative deflection, right? And R waves. We have R waves, and then we have S waves. Again, another negative deflection. Your R wave is positive, your S waves are negative, and your Q waves are negative. And you have your T waves. Okay. And the last one, 3.8, you do have P waves. Okay, you can see your P's. There's no Q wave, and there's actually no S wave. So you only have an R waves. And again, if you looked at a different lead, you probably would have S waves. So, and possibly Q waves. Again, this is just one view of the heart, and it doesn't mean that there's anything wrong with it. And you have your T waves. So if you have a QRS, usually you do have a T wave, because if you have depolarization, you should have repolarization. With cardiac monitoring, the reason we do is it provides a continuous assessment of your cardiac electrical activity. I cannot emphasize enough that you are only looking at electrical activity. You cannot see or feel a pulse just by looking at a monitor. There's rhythms that you could potentially have electricity or normal looking complexes, but not have a pulse. However, you can't have a pulse if you don't have electricity either. So you can have electricity without an actual pulse, but you can't have a pulse without electricity. So the benefit of these cardiac monitorings is that it provides a high and low rate alarms. Normally you will have alarm rates, a lower and a higher setting, usually default to the manufacturers, but your facility will oftentimes have in your policies what the low alarm and the high alarm would be set at. So for example, it might be 50 and 150. But you can also change those. So if you have a patient that is normally in a heart rate of 40s, but that works for them, then what you would do is you would lower your lower rate alarm to make sure that it didn't continuously ring off. And same thing for also you have system alarms that interpret a rhythm change. If your basic rhythm is going along and then all of a sudden you have a change in the rhythm from a different origin within the heart, it may not trigger a high rate alarm or a low rate alarm, but the system will determine what the base rhythm is, and it will hold on or save changes in the rhythm so that you could go back and see. And it usually will alert you when there's been a rhythm change. So that's always a good thing to note, that you will it'll pick up rhythm changes. You have the option for hardwire, which is usually mounted in the wall, and telemetry, which is a size of a transistor radio that you can wear around and allows mobility of the patient while monitoring the heart. You also have choices of multiple leads. Again, when we're talking about leads, we're talking about views of the heart. If you have a 5-lead wire system, it allows you to view 12 views of the heart, or you can look 12 leads we can talk about. But optimally is a 12-lead EKG, but with a 5-lead you have better views. You have more options for views, such as, this is going to look at your 2, you're going to be able to look at your V leads, your 1, you can see your 3. So there's lots of ability to look at different leads in a 5-lead. Placement is pretty important. You want to place the leads intracostal. You don't want to place them on bone, so away from bone. Your right arm lead is usually, if you have colors, is usually white. So white is on right, and this would be white, and then the right leg would be green, so snow over grass or the trees. Your left arm lead is black, and your left leg lead is red, so smoke over fire. And your center, or your C lead, is actually should be in the position of the V1, which is your 4th intercostal space, and it should be on the right side of the sternum. That is your V1 position. So for your 5 leads, you should have, again, don't put them on arms because your arms move and that's going to cause artifact. So put your leads in good position, especially your V1, and you'll get better views of the heart. Some units only have 3 lead wires, such as a monitor or a portable defibrillator, or some systems just use 3 leads. The issue with 3 leads is it limits the amount of views you can have the heart, so you can only do your limb leads, 1, 2, and 3. So you have a right arm, which is white, you have a left arm, which is black, and you have a left leg, which is red. So again, you mostly can only do limb leads. However, you can move to a V1 position or a V6 position when they call that MCL1 or MCL6. Common problems that you will find within your ECG monitoring is that artifact. It's very important to make sure that you can identify the difference between what is real and what is artifact. And I can tell you, even as an experienced nurse in ICU, I have seen many times that patients' rhythms looks very suspicious of VTAC, and I go down there and look at the patient and they're brushing their teeth or they're getting chest PT. So again, always check your patient, treat your patient, not the monitor. So it's always important to be able to identify the difference between artifact and what is real. But one thing that will help with minimizing artifact is making sure that you put the electrodes on a clean, dry skin. Oftentimes, patients could be very sensitive to the electrodes, and you may have to change them daily. And check the center of the electrodes for moisture. If these electrodes have expired, the conductant gel that's in the middle of those electrodes will not conduct well, so therefore they will not pick up well at all and cause more potential for artifact. So it's always important to make sure that the electrodes are not unsealed for a long time or if they're not expired. In the no conduction, the flat line, it is very important to go check your patient. In addition to monitoring problems may be caused by absence of cardiac electricity, also caused by dried out electrodes, loose electrodes, or disconnected wire. So always check your patient. At one time, that might not be the electrodes are loose, it could be the patient that is expired. So you make sure you always check your patient. And also to minimize this artifact, as I said before, try to put it in a less sensitive area. So don't put it on arms or shoulders because those will usually be moved and any movement will show up as artifact. Other common problems is, and the top one is low voltage. We talked about this a little bit in the earlier, where patients who are obese or have a lot of edema or have a barrel-shaped chest, they can, again, it's looking from the outside in, it might make the complexes look very small. You can increase the gain, or what we call is sensitivity, or the size on the ECG to make them look bigger. And again, sometimes you would have to do that to make sure that they can pick up the rate. The other problem on the bottom is muscle tremors. So evaluate your patient, and they might be either shivering or they might be seizing, so it is important to check your patient. And if there is persistent, then you might want to move your electrodes to a less sensitive area. If your patients are on telemetry, oftentimes the patient may drop their telemetry or their monitor because they were either walked out of these into a dead zone, what we call is an area that's not picking up reception. Other things can be caused by weak batteries, or the patient left the reception area, so they may have gone down to the elevator to go outside and take a smoke, but this is indicated that the patient is either outside the reception area. Again, if weak batteries or anything like that will cause also a loss of reception. So it's usually a policy to change batteries daily or recharge batteries if the patient's not walking around. The top one probably won't see too often, but it's what causes that is a leakage of current. And it can result from multiple pieces of equipment in use or from improperly grounded equipment, exposed wires or loose connections. And what it'll pick up is, this weird baseline. So then what you need to do is disconnect any equipment not in continuous use and begin to unplug other equipment until the cause or is identified or it removes that staticky look. Just don't unplug the vent. On the bottom one, you have this wandering baseline, and this is often caused by respiratory movement. And although you can count your respiratory rate in this matter in some ways, but if it's persistent and you can't get a good baseline, you may want to reposition the electrodes to a less sensitive area as well. When we talk about analyzing rhythms, there is 6 steps that we're going to talk about in the same sequence in analyzing rhythms. Now, Huff in chapter 5 mentions the first 5 steps. We included step 6, the measurement of the QT interval, due to its importance. We need to always be aware of abnormal long QT intervals, and that is greater than half the previous R to R, because that causes an increase in the opportunity for R on T or VTAC or VFib develop, which again you'll learn later in this course. And the QT measurement is required as part of the homework and strip interpretation rules. So we will review it. Whenever you do your homework, we always do a review of the homework. So make sure that you do a QT interval. And again, we'll give you the correct answer because it's not going to be in the back of the book. When you do your homework, you will compare what you're doing to the back of the book. And again, if you're finding that you are off by a lot of, usually don't worry about one box or so, but if you're off by a lot, it might just be where you're measuring. So therefore, contact your educator or your mentor or your preceptor and have them work with you so that you can make sure that you're measuring correctly. or go back to any of these lectures and review the part of measurements to make sure that you're doing it correctly. That's the beauty of the online. You can always go back and review more of the content. So the same sequence that we're going to start with is regularity. You're going to get the atrial and ventricular regularity. So your atrial would be your P wave, and ventricular would be your QRSs or your R waves. So with this, in regards to today, we're going to primarily focus on your ventricular or your R waves regularity, because we're in sinus right now, and so the P waves are going to be right with the ventricles. But later on in this course, you will be measuring the atrial regularity as well. Same as the rate. You will determine your atrial and ventricular rates. And again, primarily what we're going to focus on is the ventricular rates. And as we go into your atrial rhythms, we'll be teaching you how to do your atrial rates as well, because some of them will be faster than your ventricular. And then we're going to do the P wave analysis. We're going to identify where or what the P wave looks like. Obviously, if it's upright and they're rounded and they all look the same, we know that the SA node fired, so we're going to call it sinus. And especially when we talk mostly of the sinus rhythms. But as you go through the atrial rhythms, you might be calling that P wave different, something different. And if there is a P wave, we are going to do a PR interval. So if there's a P and an R, we're going to measure the PR interval. And we're going to also measure the QRS duration and the QT. Later on, when we talk about the different rhythms, you're going to talk about where did the rhythm origin and identification and the clinical significance and the interventions that you would do. And your job, whether you're a monitor tech or a nurse, so the monitor tech will have usually different responsibilities by notifying the nurse, or the nurse may have to interpret the rhythm and then notify the physician if there's something that's significant. So looking at regularity, atrial would be P to P, ventricular would be R to R. Regular rhythm intervals vary by less than 3 small boxes. So again, if you're looking R to Rs and you're counting how many boxes in between your R to Rs, it would mean that it would be less than 3 boxes. Whereas irregular rhythms must vary by 3 or more boxes of the small boxes. We check our regularity by using calipers, or if you don't have calipers, you can use a piece of paper and paper and make marks and then follow along each of the R to Rs, and we'll show you how to do that. In this strip, and this is page 33, figure 5.2, this is considered a regular rhythm. Now, with this regular rhythm, it has R to Rs, you're counting and you're putting your calipers on the first 2 R to Rs. Then what you're doing is you're moving this part of the caliper over to this one, and this one goes to the next one. Same thing with the next R to R. So you move your calipers. I like to just pick them up and move them so that to see if they are the same distance apart, and they are. So this R to R has no variations. It is exactly the same number of small boxes apart. So we would call this a regular rhythm. In the top 5.3 on page 35, this R to R is not regular. So it does vary by actually 5 boxes. So if you're comparing this R to R to say this R to R, it is off by 5 boxes. So we would call that rhythm irregular. And the bottom one, so if you're doing your R to Rs, there is a slight variation of 1.5 boxes between one of these sets of R to Rs. So what that means is that it's still a regular rhythm because it's less than 3 boxes. So we would consider this rhythm as regular. Once we've determined that the rhythm is regular, then we can calculate the heart rate. And you can do this 2 ways. you can use the 6-second rapid rate calculation, which is appropriate for all rhythms, whether it's regular or irregular, where you count the number of complexes or R waves in a 6-second strip and multiply that by 10. And we'll review that. The small box conversion table, or the small box, is used only for regular rhythms, and it is used because it is much more precise than using the 6-second rapid rate calculation. So you count the number of small boxes between R waves, so from one R to the next R, and then divide it into 1500. Or an easier way is to use the conversion table. So if you have your book, you should have your book while you're doing this, and open to the back of the book, and there is a conversion table. If you don't have a detachable one, there's a one that's in the back of the book. So looking at this, if you have a conversion table, you're going to count how many small boxes between the R waves. Again, this would only be used in a regular rhythm. So if you have, we'll say 20 small boxes in between the R waves you counted, and you have, therefore, you would look at your table, you see 20, go to the right where it says rates per minute, and that would give you a heart rate of 75. So this is important for you to remember, because if you're doing even in your test and on your practice strips, if it is a regular rhythm, the expectation is that you will use the conversion table and come up with the actual heart rate. So let's do a little bit of practicing. So let's go back to our rhythm strips. So this is a regular rhythm we've already determined, so we can use the small box conversion table. So you're going to count, let's see, because it doesn't vary, you can count from, I'm going to make a mark here, and because it's on a heavy line, it's much easier, and I'm going to count how many baby boxes there are. So there's 5, 10, 15, 20, 25, 30, and looks like 1, 2, 3, 4. So 34 baby boxes between R to R. I'm going to go to the back of my book. I'm going to look at the number 34 for how many boxes there are. I go across and I look at what the heart rate would be. And it comes out to be 44. So this would give me a heart rate of 44. Now, if I were to use the 6-second quick heart rate calculation, this is from here to here is 150 baby boxes. I already did the math. So I'm going to count how many R waves in there. So I'm going to draw a line. So I will only count the R waves between this 6 seconds. So I will not count that complex. The P waves don't count and the T waves don't count. Only the R waves. That's what you do a 6-second quick heart rate calculation. You're only using the R waves, or the QRS complexes. So we have 4. So our heart rate is around 40-ish, but more exact, it is 44. Let's look at the other one. Now the top 5.3 in 5.3, it is considered irregular. So therefore, we will use the 6-second quick rate, because we can't do the small box conversion table, because if I measure from these two R to R's, I would get, I think, 22, 10, 20, about 10, 15, 20, about 22. So that would give me a heart rate of 68. Whereas if I measure between these R to R's, and there's only 5, 10, 15, maybe 18, and that would give me a heart rate of 83. So that is why you wouldn't use the small box conversion table when you have an irregular rhythm, because it depends on which R to R you measure. So we are going to look between the 6 seconds from this one to this one. So we will not count this R wave. So we're going to count, we have 1, 2, 3, 4, 5, 6, 7, 8. So the heart rate's about 80-ish. So that's what we would use, how we would use our heart rate. For an irregular rhythm, you use the 6 seconds. And on the bottom, this is also considered a regular rhythm. Now, I know that there's a couple R to Rs that vary by 1.5 squares. So then you think, well, which one should I use? So again, you should measure every R to R and majority rules. So if they're primarily, you're measuring from your R to Rs, and most of them are the exact same part. Maybe these two are off by 1.5, and this is measured the exact, and maybe this one is off by 1.5. So again, you would use the R to Rs. That would be majority rule. And I believe that there is 26 boxes between the R to Rs, which would go in the back of the book. Look at 26 and look across, and that would give you a heart rate of 58. And if you use the 6-second strip for a quick analysis, again, your first part of your 6 seconds starts here, your second is here, so there are 1, 2, 3, 4, 5, 6 complexes. Your heart rate could be 60-ish, but more exact, it's 58. So doing the small box conversion gives you a much more precise heart rate. After you've done your regularity and you've done your heart rate, then we're going to do our P waves. We're going to evaluate the P. Is there a P for every QRS? Is there a QRS for every P? Are all the P waves the same size, shape, and position relative to QRS? And again, your P waves is represent atrial activity or atrial depolarization. So if we see all the P waves that are upright, we're going to call them sinus. If they're inverted, then we were probably going to call them junctional. But we're going to focus mostly on sinus right now. So after you have a P wave and you have an R wave, we're going to measure the PR interval. And again, you're measuring from the beginning where the SA node fired, and it goes through the atriums and through the AV node until it gets to the bundles of His. So you're measuring from the very beginning of the P wave, where it starts going up, to where either the Q wave or the R wave. So you're measuring and counting how many baby boxes between from the start of the P to the start of the QRS. And again, you will count the boxes and multiply that by 0.04 seconds, and that would give you your measurement. A normal PR interval is 0.12 to 0.20. This is something that you should memorize because, again, as we go forward in this class, you should remember what a normal PR interval is. And again, you should also remember that every baby box is 0.04. So normal PR interval, 0.12 to 0.20 or 3 to 5 boxes. After your PR interval, we're going to measure the QRS. And this is kind of hard because it's so small and it's so hard to count boxes in between. So you're measuring from the beginning where the Q starts or the R starts up, and then where the S wave comes up to the J point, or if there is no S wave, where your R wave comes down to the isoelectric line. Your normal QRS should be less than or equal to 0.10. So that's about 2.5 boxes. For examples, so you're measuring, and again, one of the key things I suggest is to use a magnifying glass so you can see, or download the handouts and make them bigger on your computer. Or I've had people take pictures of the homework on the strip in the book and make it very big. Take pictures with your phone and make them very big, and that way you can see the lines much better. So in this first one, 5-7, you're measuring from the beginning of the QRS to where the S wave comes in, and it is about 2 boxes. So 2 boxes times 0.04 equals 0.08. In 5-8, you don't have a Q wave, so I'm going to go right where the R wave starts. I'm not doing a good job. Let me erase that. So we have start from the R wave, and I'm still off a little bit, but to where the S comes up to the ST segment, or your J point. So you're measuring, basically, looks like 3 boxes, and you multiply that by 0.04, and that would be 0.12. In the 5-9 one, let's see, you have measure from the beginning of this R wave. Now this one has ST elevation, so it's almost like you have to kind of pull, I'm going to try and do it slow, pull it down so that you can measure and count how many boxes. And it looks like about 4 boxes, so it would be 0.04 times 4 boxes, and it would equal 0.16. In 5-4, it's very small, so it looks like you don't have a Q wave or an S wave, so you just have a little 1 box. So your QRS is 0.04. In 5-5, you're measuring from the beginning, and you have your S wave, and you're measuring, so you have about 1.5 boxes actually, and that equals 0.06. So you can do half boxes. So if it's not 1 and it's not 2, it's 1.5, then you would say it's 0.06. And also remember, and especially in a strip of multiple complexes, you may have a QRS that ranges from 0.04 to 0.08, but still they're normal limits. So again, you might have variations in your measurements, and it's okay, that's normal. So I'm measuring the last one, and it looks like about 2 boxes, and it is 0.08. When you're measuring your QT, you start from the QRS. If there's no Q, you start from the R, and you extend all the way to where the T wave goes back to the baseline, or the isoelectric line, and you count how many boxes, and you multiply it by 0.04. And again, the normal QT interval is less than half the distance of R to R in your regular rhythm. Usually you'll see measurements about 0.32 to 0.44, and you're going to find your QT is going to shorten with a faster heart rate, and it's longer in a slower heart rate. So at this point, I want you to go to page 40 through 41 and do practice strips 510 through 515. Make sure that you go through and you check your rhythm, whether it's regular, irregular, the rate, note the P waves, if they're sinus, if they're upright and they all look the same, and there's 1 P for every QRS. Then you're going to measure your QRS and your QT interval. So make sure that you do all of those, and then resume, pause the video, and then resume after you've finished it. If you want to, do a couple, resume the video and check your work, and if you then pause again and finish the rest of them, and then come back and review what we've done. So right now I'm going to have you pause your video and start working on 5.10 to 5.15. Let's review 510. So if you did your work, you should have determined that the rhythm is regular, the R to R is regular, and the heart rate would be 72. And if you're looking at between your R to R's and how many boxes you counted, you would have counted, 71. So you counted 21 baby boxes in between. So I'm just going to show you 5, 10, 15, 20, and it looks like 1 baby box. So 21, and it gives you a heart rate of 72. If you use the 6 second, you would only count the R waves between, so you would not count this one, and 6 seconds. Again, from here to here is 3 seconds, and this is 6 seconds. So we have 1, 2, 3, 4, 5, 6, 7. So 70-ish, but more exact would be 71. And for P waves, we have P's for every QRS. They are all upright. They are all look the same. So we're going to call them sinus. And your PR interval, because we have P waves, and we have R waves, we're going to measure our PR interval. So when you measure your PR, you're measuring right from the beginning of the P to the beginning of the R. And it's looking like about 3, maybe 4 boxes. And again, you should look at all of the PR intervals because there might be off by a box or so. And these are, some are 3, some are 4 boxes, or 0.12 to 0.16. So you've done your PR interval. Now let's do our QRS. Now the challenge with this one is that you have some ST depression, so you actually have to pull it up. So your QRS, I'm measuring from the beginning, and I'm kind of like right here, and you're counting how many boxes between there. And it looks like some of them are only 1 box, some look like maybe 2 boxes. So it's going to vary. So some of them are 2 boxes, some of them are 1, and we're going to call it 0.04 to 0.08, and that's okay. You will have variations within your QRS. The important thing to remember is that it's within normal limits. So your QRS we did. Now let's do the QT. The QT is a challenge because you have T-wave inversion. So you measure from the beginning of your QRS, and we're going to measure to where the T-wave comes back up to and it looks just over 10 boxes. So it looks like about 11 boxes. So we'll say it's 0.44. So one thing that to note with this rhythm is you would say that it is inverted T waves are present and there's ST depression. So that would be significant that you might want to check your patient and possibly get a 12-lead EKG. That can be a sign of ischemia with your T-wave inversions. All right, let's look at 511. So your R to R is regular, so we can use the small box conversion table. And if you did, you counted from this, you have 5, 10, 15, 20, 25, 30, 35, 40. Let's see. What is your heart rate? I think it's 42. Let's see. I think I counted wrong. 20, 25, 30, 40, about 42, and that gives you a heart rate of around 36. So your rate is regular, and your heart rate is about, it looks like 36 or 40-ish. And you have, if you use the 6 second, so you would count only 1, 2, 3, 4 complexes. So you can say it's around 40, or 36 is more exact. And when you do your P waves, there are P waves, they're all upright, they all look the same. And your PR intervals, so let's measure more than 1. All right. And I'm measuring right before the P and right before the QRS. And it looks like we have about 3 to 4 boxes, so it's 0.14 to 0.16. Your QRS, so your QRS is kind of small, but it looks like some of them are smaller than others. It looks like about 1.5. They're saying it's between 1.5 to 2 boxes. So again, it's kind of hard to see it, but if you made it bigger, you could see a lot better, and in your book, you would be able to see a lot better. So your QRS is 0.06 to 0.08, and your QT intervals. So your QT intervals, we're measuring from the beginning of the QRS to where the T wave comes to the isoelectric line. So you're counting how many boxes in between here. And I believe it came to about 11 boxes. And this one's probably because it lands on a heavy line and it comes in one box more. So it's about 0.44. So your QT is about 0.44. All right, let's go to the next one. In 512, your rhythm is regular and your rate, so there's about 12 boxes, it looks like, in between the R to R. So between these two, it looks like 10, 12. So your heart rate would be 125. If you use the 6 second, you would only count all of the R waves. You would not count this complex, and you would not count this complex. So you have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So you have about a heart rate of 120, or more exact is 125. You have P waves, they're all upright. They're a little peaky, but that's okay. We still know that it came from your SA node because they're all upright and positive deflected. So we're going to call those sinus. So with P waves, we can measure PR intervals. So I'm going to measure from the beginning of the P to the beginning of the QRS. And again, you're not just going to do one, you're going to do a couple of them just to compare. And your PR interval looks about 3 boxes. So I'm going to call that 0.12. Your QRS interval, so you're measuring from the beginning of the QRS, okay, and it looks like, I'm going to say about 2 boxes. So 2 boxes, and that would give you 0.08. Your QT interval, now again, this is a fast heart rate, so you're going to have a shorter QT. So you're going to measure from the beginning to the end of the T, and it looks like it's about maybe 7 boxes, so that would be 0.28. All right, then let's do 513. The rhythm is regular, so we're going to do the small box conversion table. So with that, you have a heart rate, you have about 27, I think, 27 baby boxes, and that gives you a heart rate of 56. Your P waves, oh, I just want to go again. So 6 seconds, again, you're only looking in between, and you have 60 or 6 complexes. You multiply that by 10, and that'll give you a heart rate around 60, but more exact is 56. Your P waves, you have P waves, they all are upright, they all look the same, so we know we can call them sinus because that's where the rhythm originated in. And with P waves, we can measure PR intervals. So we're going to measure some PRs, so we always do more than one. And I'm just kind of giving you an idea of where to measure from. So beginning of the P to the beginning of the QRS. And it looks like your PR interval is between 4 to 5 boxes, so it would be 0.16 to 0.20. Let's look at our QRSs. So our QRS has got a fat S. So we start from the beginning, and then again we move it to where the J point is, and you kind of like have to kind of go across because there's a little ST elevation. So it looks like there's about 3 boxes there. So maybe even 3.5. So 0.12 to 0.40 is your QRS. Your QT intervals, so we measure from the beginning of the QRS to where the T wave comes down. And looking at that, it looks like about 10 boxes. I'm just comparing them. Yep, looks like about 10 boxes, so your QT would be 0.40. And the last two, so 514, your rhythm is regular, but we can do a heart rate. So we're counting how many boxes. We have 5, 10, 15, and we have, looks like we have 16, 17. So that would give us a heart rate of 88. If you use this quick reference, you would only count how many R waves in this. So you have 1, 2, 3, 4, 5, 6, 7, 8, 9. So 90-ish, but more exact is 88. Your P waves, you have P waves, and they're all upright, so we know they came from the SA nodes. We're going to call them sinus. Your PR intervals, I'm going to measure a few of these. PR intervals from the beginning of the P to the beginning of the Q or S. And again, you want to measure more than just one. And it looks like we have about 4, some 5 boxes. So we had 0.16 to 0.20. Let's go to our QRS. So your measurement, there's no Q, so we're just going to go from the R and where the S comes back up. And it looks like about 2 boxes there. This one looks probably maybe, oops, 1.5 or so. So some of them look 1.5, some of them look 2. So we're going to say it's 0.06 to 0.08. And lastly, we're going to measure our QT interval. So let's see, your QT interval, measure from the beginning to about the end. It looks like about 10 boxes. Again, you're going to measure from the beginning to the end, and it's a very low voltage T wave, so therefore it makes it much more difficult to see where the end of it, but I believe it's about 10 boxes or 0.40. All right, let's go to 515. In this rhythm, it is irregular, so therefore we cannot use the small box conversion table. So we're going to use the 6-second, and we are not going to use this one or this one because they are outside the 6 seconds. So we have 1, 2, 3, 4, 5, 6, 7. Multiply that by 10, you have a heart rate around 70. So we're going to have a rhythm is irregular, the rate is 70. You have P waves, they all look the same, they're all upright. We know it came from the SA node. So we are going to call this sinus. And with P waves and R waves, we can measure PR intervals. So we measure from the beginning of the P to the beginning of the QRS. And again, you always want to measure more than one. And looks like we have about 3 to 4 boxes, so we're going to say 0.12 to 0.14 or 1.16. Your QRS, all right, so you're measuring your QRS, the little S wave there. Again, it's hard to see, but it looks like it's about 1.5 to 2 boxes. So we have a QRS of 0.06 to 0.08 and your QT interval. So we start at the beginning and it looks like about 10 boxes. So we have a QT about 0.40, and again you can make sure that you do more than one, and it looks exactly like 10 boxes. So that is your QT intervals. So you did it. So hopefully now you understand normal conduction. Again, very important to understand what normal conduction is, because going forward, we're going to teach you what's abnormal, and you have to have a true understanding of what normal is. You should be able to identify your P's, Q, R, S, and T waveforms, and how to measure your PR interval, your QRS duration, and your QT intervals. And that concludes this part of this lecture, and you will next do a sinus arrhythmias.